I think we had a very nice debate with Javier Leleu from France regarding, first of all, continuous versus fixed duration treatment, and also regarding triplets or doublets. Of course, as in every debate, these are, let's say, general titles, and of course, everyone can present data supporting its, let's say, part. But of course, in order to be fair, we have to say that continuous treatment seems to be, to date, the best option for the majority of myeloma patients. So for patients who are eligible for transplant, then a triplet induction, and then the transplant, and then consolidation, and then maintenance with lenalidomide till progression, or sometimes with bortezomib in patients with deletion 17p, for example, I think this gives the best results. And also in patients who are not eligible for transplant, lenalidomide dexamethasone as upfront continuous therapy also gives better results compared to MPT, for example. And for patients who have been exposed to 1 till 2 prior lines of therapy, we know that all triplets like KRD, LORD, ixazomib RD, or DARA-RD, or even DARA-Velcade dexamethasone, or panobinostat Velcade dexamethasone, all these triplets are given till disease progression, with the exception of the ASPIRE study where carfilzomib was given for 18 months in this study. And all these continuous therapies were more, and as a triplet, were more efficacious compared to the Lendex or Veldex, depending on for what trial we talk about. But I think that triplets continuous in the relapsed refractory setting, I think they are the regimens that give the best results. Regarding doublets, I can tell that in specific subsets of patients like elderly population, fit or intermediate fit patients that cannot tolerate triplets, I think that the doublets give very good options also. And we do have meta-analysis showing that if you are receiving a doublet in these specific conditions, elderly, unfit or frail patients, then they may have better survival compared to triplets, and this is mainly because of the toxicity. So I believe that the debate has as, let's say, a conclusion that the triplets are more efficacious than doublets. However, doublets like Lendex or VD may be very efficacious for specific subsets of patients like elderly, fit or unfit patients. And also continuous treatment versus fixed duration seems to give the best results for both patients who are eligible or non-eligible for transplantation.